Okay, so our third presentation is going to be by Sid Saidi. He is the co-founder of the nonprofit Association for Socially Applicable Research based in India, and is also a doctoral student in epidemiology at Columbia University. So glad to have you back, actually.
Wait, I can stand here. Yeah, okay, cool. Hi, thanks so much everyone for joining. I'll be talking about our project called IndoHeal Map that we did at USSR in India. And I'm sort of presenting mostly on behalf of everyone who's listed here, but also people who are not listed here. So like the first 6 names that you see on the screen, which are italicized, those are our engineers. So those are like the people with useful skills. And then the people below are people like me who are public health people, doctors, who have been helping in this project. All right. Yeah, apart from USSR, these are my other affiliations. Some of them pay me well, others do not. And then a lot of work that I'm presenting today is already out, and those are kind of the QR codes shared in the slide deck. All right. So this is a news item from last month, this year, from Maharashtra, which is my state. It's the richest state in India. And what you see here is unfortunately quite common still in rural and tribal areas. And so this is kind of like the context in which we are trying to understand geographic access to healthcare in India. Access is kind of an overthrown term in public health. People mean all different sorts of things when they say access. So I just want to clarify that for the sake of this presentation, when I say access, I mean specifically geographic access. So the ability to reach a health facility when you need one. All right. And there are multiple ways in which one can define access. So one way is to, and which is more of like a conventional way, is to look at something called facility density, so number of facilities per 1,000 or 10,000 people. This is the kind of data that's usually available in a lot of countries and that ministries, local health departments use for decision making. But there is another way of looking at access, which is more in terms of timeliness. And a lot of stuff that came out about timeliness was during the Lancet Commission on Global Surgery, where people identified that it's not just the number of facilities that you have in a given region for like a population, but it's also whether those people are able to reach the facility within time or not. So what we did was to kind of combine those two things, so population and timeliness, and look at something which I'll be calling access population coverage, which is basically the percentage of people in a region that live within X minutes of their nearest healthcare facility. And so the utility, or probably the biggest utility of this definition, is that an indicator of this sort is comparable across regions. It's comparable across time periods. And then you can kind of flexibly adjust whatever time threshold you want to look at. So X minutes can be 2 hours, that's 120 minutes. That's what people who work in surgical and emergency care look at. It can also be 30 minutes, depending on whether you're interested in primary care. All right, so the project has been largely about mapping access population coverage for health facilities in India. And the way we developed this and the way we have been working for last couple of years on this is that it's essentially divided in 2 parts. So the first part is data collection, extraction, all those sorts of things. And the second part is analysis. And it's the second part that I'll be mostly focusing on today. All right, before we dive into that, I just want to give a little bit of background. So what we have done in the last 3 years, using over 10 data sources and a team of more than 20 people working on this. We have mapped over 300,000 healthcare facilities in India. For some of these facilities, for all of these facilities, we have good geolocations data. For some of them, we also have data on their functional characteristics. So how many physicians they have, how many nurses they have, whether they have an functional operation theater, whether they have access to electricity, and those sorts of things. Our approach in all of this has been mostly and this is, iterative scaffolding is stolen from one of my friends. It's iterative scaffolding. What that means is I'm currently living in New York, and that city always has scaffolds all around. It's just constantly in the stage of repair. So I want to focus on that. That's what our approach has also been. So we extract the data, standardize it, geocode it, validate it, harmonize it, and we repeat the cycle again. And that's what we have been doing for 3 years. All right. For our analysis, our approach has been that we have tried to create a catalog of global data sets that we can use and that we can rely on. And then we kind of do contextual, relevant, local adjustments to those data sets. So for timeliness, friction surfaces, so these are kind of like huge global GIS maps that tell you how much time it takes to go from point A to B, not necessarily healthcare, but just from point A to B. We took those from Malaria Atlas project. We took population estimates from WorldPop, which provides estimates from, I think, 2000 to now 2020 at really high geographic resolution. So they have kind of like estimate for each pixel of 1 kilometer square. And then we relied on more and more new literature that's coming out about standardizing administrative boundaries within countries. So which areas should be considered rural, which should be considered urban, and all those sorts of things. And the local component here is kind of like administrative boundaries within India and how we catalog those and look at those. All right. So this is a really busy slide, but the idea was to just give you a sense of what are the basic steps involved in the analysis. I am going to take one thing from like Megan today. I really loved how you did the kind of, to your estimation pipeline. I'm going to take that and use it for this one. But we have one first step in the analysis, which is to basically create or isolate population estimates from WorldPop and kind of disaggregate them by rural and urban areas. The second component, the second box there, is to, again, crop the timeliness rasters from map and kind of pass the geocoded facilities that we have through them. So that box with like the slightly bluish boxes, that gives us a network of how easy or difficult it is to reach a healthcare facility. Once we have those two components, what we essentially do is basically a multiplication between these geographic like rasters. And we are trying to now create estimates for a specific disaggregated admin boundary, how many people live within it, and whether they are within a given threshold of time to their nearest facility or not. All right. So on the output end of all of this, what we are looking at are two modes of travel, and this is more like a sensitivity analysis. So we have walking and motorized transport. And we kind of, at least till now, we have kind of used different like time thresholds to look at those. And we are looking at health sector split wherever it's available. We are looking at, like I said, the regional split between rural and urban areas. We do these analyses to create estimates for nationally for India, 36 states and union territories, and then over 735 districts. So at the end of like a single analysis cycle for a given health facility type, let's say primary healthcare center, what we get are about somewhere between 30 to 40,000 estimates for that facility type based on the geographic hierarchy and all the disaggregations. All right, so my goal today is not to take you through, like 100,000 estimates, but just give you a flavor of what we have done till now and highlight maybe some of the things that we think could be useful and could be important. All right, so the first map as part of like results that I'm going to talk about is access to primary healthcare centers. So these are first point of care seeking within the larger setup. So India has primary healthcare centers, then community healthcare centers at the secondary level, then district hospitals, and then medical college or teaching hospitals that for the tertiary level. And what you see here is a district level map of people who are within 30 minutes of their nearest PHC by walking. One of the things that I want to know, I don't know if I can do this. Oh, yeah, I can. Okay. Wait, is it possible? Yeah. So one of the things is you start seeing geographic clustering. So there are regions here in southern India where more people are covered within 30 minutes versus parts of here northwestern Rajasthan and even northeastern and central India, where it's probably somewhere under 20% of people who can reach their nearest PHC within 30 minutes. All right, moving to secondary level of care. And this sort of looks really different, right? So now we are looking at how many people can reach the nearest community health center within 2 hours by motorized transport. A huge asterisk here, well, two actually asterisks here are, one, we are assuming optimal travel speeds, which is not a realistic assumption to make. And two, we actually do not have data on whether these CHCs are functional or not. So this is specifically just whether people can reach or not. And that's why you will see something, oops, oh, my bad. Oh, wait. I'm not doing anything, but still going through. Okay, cool. Yeah, so what you see here is a lot of places in northern India and also southern India. It's over 99% people who can do that. And this sort of flagged us off to say that maybe we need to look at more things when we are talking about geographic access. And so let me run you through an example of where we were able to do that due to availability of data. So while looking at district hospitals, we had data on, so these are about 700 district hospitals all around the country. We have data on, like I said, functional characteristics for these. And what we did was we classified them according to like an efficiency criterion, which was based on how many surgeries they can conduct and whether they have essential services that are needed for conducting those surgeries or not. And I mean, immediately you can see that there's, again, sort of like places here. So this is Uttar Pradesh, which is the largest state in India geographically and population-wise, but also has a lot of socioeconomic and developmental issues. You can see that that's the state where you have fewer efficient district hospitals. Okay, but then and that's sort of what we see when we compare timeliness with respect to all district hospitals, so which is this map, versus only taking the ones which are efficient. And so there are small differences. So one that I wanted to highlight here, you see way more people within 30 minutes in this case, versus here you now start seeing kind of like small pockets where people are even above 120 minutes from the nearest efficient district hospital. Similarly, there's also kind of like widening of this region compared to this one where you're losing healthcare access. All right. And so we are back to seeing what percentage of people are within 90 minutes of their nearest district hospital by motorized transport. Again, one thing that I want to note here is this sort of like belt that you see. This is most likely because most of these regions are urban and have really well-functional district hospitals, not just because the hospitals are functional, but because the health system is doing well. All right. The last kind of like hierarchy in the health system, looking at medical college and teaching hospitals. And so we sort of see what we expect. This is almost like an area under the curve kind of plot, looking at how population access improves across time thresholds. And we are looking at sectoral split here. So public versus private, and at least for teaching hospitals, it looks way better for public hospitals in India. I kind of want to focus on just one disparity here, which is rural-urban disparity in India. And so what you see here, let's go to these two first. For district and medical college hospitals, when at the national level, you have over 98% people who have access to district hospitals. In urban areas, that number drops down to 90 for rural, kind of like similar for medical college teaching hospitals. But for primary and community health centers, since those are mostly located in rural areas, you see that pattern flip, where rural people have more access, at least by walking, than their urban counterparts. And so we are sort of like diving deeper into this idea of rural-urban disparity, and we are also trying to like extend the analysis to beyond India globally. And we think that this particular disparity is definitely an indicator that we should be looking into as part of larger healthcare access. All right, a couple of things that we are working on right now and that we plan to improve in the future. We are trying to now incorporate floating catchment area kind of models using the functional characteristics. A lot of we of course like inherit all the limitations of the data sources that we are using. The biggest limitation probably is lack of uncertainty estimation in those. And then we are right now partnering with some NGOs and some state ministries to do more ground validation of the estimates. Three quick implications that I want to go over. One, like I said, we think that access population coverage definitely has a place in health system indicators, including a place probably in SDG 3. Access disparities should be high on policy prioritization, especially for rural areas in case of India. And then the end goal here is to do what Betsy just showed us on her slide 17, which is to incorporate all of this into GIS-enabled apps that can improve healthcare and interfacing with the patients. Thank you so much.
Wonderful bit of work. It is really impressive to see the comprehensiveness of all of the different permutations that you've looked at.
Hi, thank you for the presentation and beautiful maps. I'm wondering if you can talk more about the data that you said 300,000 health facilities you have geocodes for. And also a lot of your maps were about like public sector facilities. So if you can talk about the private sector coverage in that data set, since a lot of 50% or more outpatient care takes place in the private sector in India, depending on the state, would be good to. Yeah. No, that's a brilliant question. Like Indian health system is really fragmented. You're right. Like we do have a huge private sector. So what I showed today is mostly public sector. Some of the data sources that we now have do include private sector facilities. They do not get classified at the primary or secondary level. And most of them, even if they are providing primary care, still get classified as tertiary facilities. And that's just because the Indian government has its own hierarchy of healthcare facilities, and no one within the private sector would like to, kind of like embellish and like venture into that. So
I think the only like sectoral split that I talked about today was at the teaching hospital level. But for a lot of like tertiary care centers and maybe some secondary care centers, we do have, like private sector health facilities. My guess would be of the 300,000 or so facilities, about at least like 130 are private. So yeah, like a little less than half. Yeah.
Yeah. Okay. Hi, thank you so much and congratulations. I'm a fan of ACER since last year we met here. I have one more like number question and one non-number question. In the maps, I saw the thresholds for the color codes were different. I was wondering what was the criteria for determining this, and I'll throw in my other question at the same time. Is that okay?
Yeah.
So once you have these results, what is ACER's like connection or process to transmitting these to policymakers and helping them make decisions based on these?
Yeah, thanks. So yeah, I mean, at least for the maps, that I had here today, we kind of like chose those thresholds based on. So we do a bunch of things. Like one, we use thresholds that are in the literature. So like I said, like Lancet Commission has a target indicator that 80% people should be within 90 minutes to 120 minutes of their nearest like district hospital. So that's why a lot of those like percentages in the map start from like below 80 and then like above 80. So yeah, we try to use like existing literature for that. In places where that's not there, we have to rely on just like the data and like internal distributional like properties. So like looking at like median or like any of those. For your second question, there was initially like a huge buy-in from the central like government and like their health ministry for something like this. I don't know the exact reasons, but that has decreased in past few years. So our approach of kind of like navigating the policy space has been that we work with state level health ministries. And we are trying to, so what we basically do is give them like a one-page policy brief like pamphlet and list the districts that we think really urgently need improvements in like infrastructure of their PHCs or like district hospitals. So that has been like more like grassroots way of doing things right now. Yeah.
Great. Okay. One question. Brief, please.
Thank you. Congratulations. Just one question, methodological perhaps. If I understand, you have one layer that's all the facilities, for example, another layer from the census with the radial census of where people live, and there you have the distances. But for example, for the time in motor transportation, there, when we try to do something similar, we found the problem of public transport and the time when they are coming and the delay about the journey. How did you match that for the whole country? It's impressive.
Yeah. So, I mean, so like this work relies mostly on like MAP, and then MAP has like freely available friction surfaces for, like those kind of like timeliness that you're talking about. They do have different layers for like public transport and like places where it's not public. Also places where they have like waterways, which I think is more relevant for like Amazon. So till now we have relied on MAP. Now we are taking a different approach and we are kind of like doing it more locally, and due to like whole like computational constraints, we can. So right now we are using more of like Google Maps data, but we can only do that for at max, I would say like a district, not more than that, because it just gets like computationally really heavy.
Seems like we should recruit some of our tech friends to get you computational power and amazing. Data.
Yeah.
If anybody knows anybody at Microsoft, we should make that call.
Thanks so much.
Okay, great. Thank you so much.